ask Representative Collins, co-chair, to talk a little bit about how this is going to end tomorrow.
What we'll do after the 4 companies have presented is use the force ranking vote the way we did to narrow the list down. This time we'll rank them each individual 1 through 4, and then we'll tally those scores and use the golf score method. In other words, the 2 lowest scores will remain in consideration, and then the task force members will vote again between the 2 that remain for their first choice. And then the firm that is chosen with the lowest score in that second vote will be the firm that we will offer the contract to. Separately, but related to all this, is the question of data. So I'm shifting gears here, but I want to cover this because as we're moving forward, lots of people have questions and are interested in data, and what we want to avoid is people going directly to an agency, to DHS, or to a third party or somebody else and asking them to get data for the task force. So what we're going to do is we're going to try and compile that in one place so that as requests come up, we can get clear requests, we can get non-redundant requests, and we can keep track of those. And so the way that we'd like that to work is if you can email your request to Jim and I, and then we're going to have somebody from BLR on that email as well. I don't know whether that's going to be Nell or Jill or somebody else, but I'm going to ask BLR to keep an eye on that because we may wind up needing a form just to make sure we get straightforward questions if some of the data requests get too complex. We're also going to have questions coming in from other places, so we're going to need to cross-check those, and Dr. Bledsoe is going to help us with that as well. So the goal here is to get us all the information we need, to get the information you actually are requesting as opposed to having confusion between your request and what is delivered, but doing it in the most efficient way for agencies and other people. We're already starting to get some requests, that's fine, but let's please send it to Jim and I, and by this request, we're also telling the agencies or anyone else, if you're not getting that request from either from Jim or I through BLR, then please bring it up to us and we'll get it in the right channel. Thank you very much. And with that, what I'd like to do is represent Ms. Longley to begin her presentation for the Healthcare Task Force.
Can you hear me?
Yes, and if you would state your name and who you're with just for our record.
Sure. My name is Diane Longley. I'm with Health Management Associates out of Austin, Texas. And thank you, Chairman Hendren, Chairman Collins, and members of the task force. It is a pleasure to be here today and come back to Arkansas. I grew up in North Texas, and we spent many summers here enjoying your lakes, and continue to do so today, especially with the drought we've had in Texas recently. So it's great to be here today. I know that all of you have our presentation, and I'm going to try and make the best use of your time and not read through the presentation, but hit what I think are the highlights and the things that we'd like you to take away about our expertise and our ability to perform the work that you've laid out before us. This is a very important initiative. We are truly excited to be considered for this project, and we'll be glad to answer any questions as we go along, of course. I have with me today 3 other members who are on our project team. I just wanted to, they're behind me there, so it's possible that if you have a really super technical question and I can't answer it, which is entirely possible, I may want to call on one of them to come forward. And I'm going to tell you though, I probably can't answer all of your questions. Part of this process is going to be finding the answers. What I can do is tell you how HMA does this work, about the incredible level of expertise and the depth of knowledge and understanding that we have, and how we can move forward with you as partners to develop a plan for building on what you have already successfully achieved and accomplishing the goals that you have to provide coverage in a fiscally responsible way and increase personal responsibility and get people in Arkansas covered by healthcare coverage. Real quickly, I come from the Texas Department of Insurance prior to joining Health Management Associates about 4.5 years ago. I was Director of Health Insurance Initiatives at the department and have spent my entire professional career working on health insurance issues for the Texas legislature, the department. I oversaw the initial 2 years of health insurance reform before joining HMA, and I'm glad to bring that knowledge and experience to this process. Linda Wirtz is also here with me today. She is also managing principal with HMA and was a former Texas Medicaid director prior to joining HMA. And then I have Ray Hanley with the Arkansas Foundation for Medical Care. And I'm sure that most of you are probably have met Ray before and know about his experience as the former Medicaid director here in Arkansas. And then our actuarial partner is Wakely Consulting Group, and Christine Bach with Wakely is here today as well. I apologize for this first slide. Something happened in the format, but hopefully your handouts will, everything else will be fine. So the presentation today is organized really based on what the criteria were for the evaluation of the RFP. I know there are a lot of different ways to lay this out, and we tried to come up with a way that made sense without spending a lot of time on information that you don't really need. So as I do the presentation, I'm going to point out, some of the highlights of where we believe that we have met the requirements of the RFP. So the criteria is our team's experience, the proposed personnel and the expertise of the people that will be working on this project, our past performance as a consulting firm, our plan for providing services, the schedule, the ability to perform work and attend meetings, which I know is a very important requirement for this work, compliance with the requirements of the RFP, and finally, we're going to talk about the price of our proposal and how we reach that important number. So HMA has been, we are actually celebrating our 30th year right now. And by right now, I mean this very day. Our annual HMA retreat is in Virginia right now as I'm sitting there at this table. So they're very excited to have been in this business for 30 years. Healthcare is all we do. And some of you have probably never heard of HMA. We're not a huge firm by, compared to some others that you are thinking about. But the quality and the work ethic of HMA staff is truly unsurpassed. HMA does not post jobs. They specifically recruit people who have the unique skills, the experience, the knowledge that they need to provide the work that we do. We have 16 offices now across the country. In our proposal, there's a list of all of them. We have more than 125 staff right now, and we continue to grow literally every single week. Included in our staff are former Medicaid directors, CMS and society staff, insurance regulators like myself. We have physicians, nurses, pharmacists, IT experts who both have developed IT systems, who do analytics for agencies, who work with private insurance companies on developing their IT expertise. We have attorneys, several of whom, well, most of whom actually have extensive experience working on Medicaid waivers specifically, financial analysts, and then research and evaluation staff. For this project, we have a list of people, all of whom are identified in the actual proposal. And it includes 7 former Medicaid directors with almost 200 years together of combined Medicaid experience. We also have 4 former program staff who have worked with Medicaid agencies across the country, 6 former employees with Office of Management and Budget, CMS or Society, 3 attorneys that are working on this project, all of whom have extensive experience helping states develop Medicaid waivers. The 2 insurance regulators that I mentioned, myself included, 3 clinicians, all of whom have worked with Medicaid program evaluation projects, 3 health IT system analyst specialists, and then we also have access to the entire HMA staff as needed. So although we've created this team that is very uniquely and carefully selected based on their expertise and the work that we're going to be doing for you, we also literally at a phone call can pick up the phone and tell someone we need some additional assistance in this area. We don't have a corporate process to go through where we have to get approval or go through a lengthy process of getting people on our team. All we would need to do is to request them and then clear it with you to be sure that you have no problems with the addition of that staff to this team. We have clients across the entire country. These are the states where we either currently or formerly have been working on Medicaid-related projects. We have 36 states, District of Columbia, Guam, and somehow Puerto Rico got left off the table, so I'm sorry about that. Our Arkansas projects were primarily with the Department of the Medicaid agency or the Medicaid program. We have not done anything that we could find since 2012. But I will say we have recently converted all of our projects to a new database. And so while we search through all of the projects that have been loaded, it is possible that we missed something, but we couldn't find anyone who was aware of anything that we've done here in Arkansas since 2012. Our clients also include CMS, HRSA, excuse me, the foundations and national associations that are listed here. We do private commission contracts with us annually to do a national survey for them with Medicaid programs. NCSL has used us for several different projects, as well as the National Governors Association and the Robert Johnson Foundation, all of whom I would imagine that you are familiar with. The Mott Foundation is a Michigan-based nonprofit that does healthcare research work. Michigan is our home office, and that is how we developed the relationship with the Mott Foundation. And then we also have a lot of private organizations as well as local governments. Because of our Medicaid expertise, we contract with a lot of Medicaid health plans, managed care organizations, as well as Medicare hospitals, health systems, commercial insurers. I'm not going to read through all of this list, but you can see that it pretty much covers the gamut of the healthcare industry. As I mentioned at the beginning, one of the partners for this project is the Arkansas Foundation for Medical Care. We felt like it was important for us to have the Arkansas expertise that the foundation can provide. Their experience with Medicaid, with program analysis and analytics is probably unsurpassed in the state. They have done an extensive amount of analysis related to program performance, outcomes, measurement, and evaluation. They have 194 staff who have expertise in clinical medicine, data management, quality improvement statistics, and I know that they're going to be a very useful partnership for this, this endeavor. They also have an office that is located, I think, about 4 blocks away from the Capitol. So as we visit Arkansas for our meetings, we'll be working out of their offices. We will also have them here on the ground at any time if there is a need to attend a meeting and we are not here in town. If it's something that comes up at 9 o'clock in the morning and we want to have a meeting, or one of the staff want to have a meeting that afternoon, we'll be able to conference in, and we'll also be able to have someone from the foundation here to represent us if that's inappropriate for the meeting. Our other partner for the actuarial analysis is Wakely Consulting Group. They are a national consulting group. You might have heard about them before. They have more than 20 credentialed actuaries. They specialize in healthcare financing. They work with Medicaid state agencies as well as Medicare, health insurers, hospitals, physician groups. They have an extensive amount of experience with healthcare reform, modeling, financial analytics and projections, public policy development, design, and we are very excited to have that expertise. We know that actuarial analysis is going to be one of the critical components for this project, and although it's one of those specialty skills that requires an actuary, we also will be using the data analytics expertise of the foundation, as well as our own staff, many of whom are not actuaries, but have done a lot of financial modeling and analysis both for Medicaid agencies and in their capacity working for CMS, as well as working for our private clients. I want to talk a little bit about our relevant experience, and by relevant, I mean the experience that is really related to the work that we would be doing for you if we're chosen for this project. We tried to count how many Medicaid waivers we have actually either written from the design phase, putting together the application, negotiating with CMS, every aspect of Medicaid waiver, and we literally could not come up with a number. It is hundreds between the people that we have now who are working on Medicaid waivers as part of HMA staff, as well as those who worked on Medicaid waivers when they were working for Medicaid agencies throughout the country. We have also done Medicaid delivery system evaluation, transformation and improvement, all of the delivery system redesigns that focus on payment reform. We have a team of people who spend a good deal of their time looking at and doing analytics for Medicaid departments on enrollment and eligibility system evaluations, helping them with a redesign. We have a project in South Dakota right now that's been going on for about 18 months, and it's going through, I believe, the end of 2017. So it is a full-scale redesign of their enrollment and eligibility system, as well as some other projects. But that is one that has been basically turned over to us for completion. And then we also have a great deal of experience looking at utilization, expenditures, and the Medicaid programs, as well as commercial market business, which is important since your private option is commercial private oriented. So it's not just about what's going on in the Medicaid market, but what's going on in the commercial insurance market. Both of those are very important. They're important in doing cost projections, cost analysis, and also in looking at the modeling and what the impact might be, changes you make in Medicaid, how it might impact the private market, and vice versa. So we see the interplay between those two programs as being a critical part of the analysis that we will be providing as part of the analytics as well as the background research. And we also have done a great deal of work in health reform. My very first project working for HMA was spending about the better part of 6 months in the state of Nebraska helping them figure out what health reform meant to the state for their insurance market, developing some cost projections for what they would be doing, some of the alternatives that they were thinking about with regard to both expansion as well as development of an exchange. We've also worked with about half a dozen other states extensively on different areas of healthcare reform over the last 5 or 6 years. A few recent projects that we've done, again, is assisting states in the preparation and analysis of 1115 waivers. And attached to your handout should be 2 tables. One of them is a chart that has Medicaid and 1915 waiver project summaries. I'm not going to go through these. It's just provided to you as an example of some of the projects that we are currently working on or have been working on recently. And then secondly, there is an experience requirements matrix. It also talks about the waiver work as well as some of the other projects that that we either are working on now or have worked on recently. So I'm, again, not going to go through these, but I think they highlight the expertise that we have, the technical assistance to states implementing or managed care. We've worked since the very first state adopted managed care for their Medicaid program. HMA has been involved in that process. When HMOs were first invented and no one knew what a managed care organization looked like, HMA was involved in getting those off the ground and helping states figure out whether it was a good choice for their state, working with them to identify the differences between a managed care program and the fee-for-service structure and what it meant in terms of the financial impact on the state, as well as the delivery system. We've worked with multiple states on their EMIS upgrades, their Medicaid management system, and helping them evaluate and analyze their IT capabilities and where their weaknesses are, what they needed to focus on in terms of getting up to speed so that they could meet the demands of the market and the providers that they work with. And then we've also had numerous projects where we have evaluated the state prison systems, their correctional health care. We have 2 people on our project team who will be performing that work specifically for this project if we're selected. They have in their bios, you'll see some of the work that they have done working for other states on this very issue. And then finally, providing assessments of economic cost and the benefits of the changes in the healthcare system and the impact on the state. And this is an area where almost everyone who is on this team has some experience doing it. So it's not just 1 or 2 people. It's really a cross-section of people who bring different skills, different experience, different levels of understanding, but they look at it from all different perspectives. We have the attorneys who look at it, we have the IT specialists, we have the policy development, we have the analytics. So we bring not just one perspective, but we look at it from every angle. We argue with each other. We talk about what if you did this instead. We talk about what could we do differently to make it better. What's wrong? What can we fix? And that is one of the greatest things I think personally about working at HMA is the fact that we do have people with so many different backgrounds. We leave virtually no stone unturned. Everything that could possibly impact the dynamics of this program will be discussed, evaluated, and really put under a microscope to see what could we do better, what could we do differently. Just highlight a few of our recent Medicaid waiver experiences. And you know, I asked not just our team, but the entire staff at HMA, if anyone could remember ever developing a waiver that was not approved. No one could remember one, certainly not in recent years. It's definitely possible. 15 years ago, some prior employees had an experience with a waiver that ultimately was not approved. Well, that's not to say it was approved as initially written. As you all know, developing a waiver involves negotiation with CMS. We have groups of people who do that, who are doing that right now on behalf of some clients. But I just want to point out that we have an incredible track record of successfully developing and implementing and getting approval for waivers. It was an important outcome of this process. Recently, the Texas Medicaid agency applied for, I say recently, it's been 4 years ago now, applied for a delivery system reform, incentive, payment waiver, a district waiver, which some of you probably heard about. It's a new way. Texas was the 2nd state to get one of those waivers. And HMA, including Linda Works and myself, and as well as some other team members, have worked with our Department of Health and Human Services from the beginning to design that waiver, negotiating with CMS, developing some of the cost impact modeling, and then getting the approval. And now we are working on the waiver renewal renewal with the Department of Health and Human Services, which will be submitted in September. We also have been working with providers throughout the state. Under the district waiver, the entire state was granted a little over $29 billion in federal funds over a 5-year period. And these projects are all being implemented, were created and implemented by providers across the state, hospitals, health departments, mental health agencies. And we've been working with 4 of those regions in the state: Houston, which is Harris County, Austin, Travis County, the coastal Bend area, and the Bear County area. So we think the district waiver may provide some opportunities for Arkansas when you start talking about potentially combining an application for an 1115 waiver and a 1332 waiver, which we're going to talk about in just a few minutes.
Diane, would you just give a little bit more detail about what a district waiver is and what you did? It's a $29 billion waiver in Texas.
Sure. So when Texas opted to expand managed care throughout the entire state, the Medicaid program was at risk of losing a good portion of our uncompensated care funding. So the district waiver was an approach that had initially been used only by California, but it allows the state to collect money, or the providers to collect money. You have to put up the state match, and then you draw them the federal dollars. So the program itself is, there's a compendium that is about 1,000 pages long that provides all of the program options. And it allows local communities, the providers, to get together, work together, and choose projects that they want to implement. Some of them are things like behavioral and physical health integration, expansion of clinics for low-income residents. There's so many projects. Some of them are working at like an EMS in a rural community, doing home visits to provide services for the elderly or people who don't have transportation. So when they're not doing emergency calls, they actually go to people's homes and check their diabetes, their blood levels, and perform other types of services. There are about 400 different types of projects that you can choose from. CMS has indicated that they probably want to streamline that in the next go-around. The beauty of this process is it's locally based. It's local providers deciding what works for their community. It is a significant amount of money that goes towards providing healthcare services. The payment system is based on meeting metrics and milestones that are included in the compendium documents that we negotiated with CMS. And the providers get paid twice a year, I believe, on our funds for meeting these metrics and milestones.
And you mentioned they were at risk of losing some of their dollars for uncompensated care.
Correct.
How does that, why is that? Does Arkansas have the same challenge, or is this some of the same issues we hear with the state threatening to sue the federal government if they don't expand, they lose these dollars? What kind of threat was that, and why did they have to do that?
Well, for Texas, it was really because we were doing the managed care expansion, and that was the reason we were going to lose the dollars. I don't think that threat is imminent here in Arkansas, but there are other states that are looking at district as a way to provide flexibility in the way they deliver services. So instead of using that money just to pay for uncompensated care, it allows you again to do delivery system reform at the local level. So instead of just sending people to the ER to get services, it allows them to build access to care, community clinics, so that people have an opportunity to go to those clinics, after-hour services. Some of the hospitals have built outpatient clinics so that they're not going to the ER. They come to the ER, we divert them over to the outpatient clinic, which costs about a tenth of the cost of seeing someone in the ER for a non-emergency service. So it was So for Arkansas, it might be an opportunity to spend your monies on healthcare delivery system reform again at the local level, taking some of those funds that might have otherwise gone to uncompensated care and using it to build that infrastructure at the local level. So some of the waiver-related tasks that HMA has the expertise and has done already, and I don't want to beat this horse, but this is just an example of the specific tasks we've done. We've done, work from the very beginning when it was just a concept or a state came to us and said, we want to apply for a waiver, help us figure out what would work for us and what we need to do. So we took it from the very beginning. We did the analytics, the research, visited with your staff, did, stakeholder meetings, and evaluated what would work for that state. We then drafted the waivers, submitted it to CMS, went through the negotiations with CMS, developed the cost benefit analysis. In some cases, we developed their strategy, helped them work through the negotiation process and identifying some of the key points that they would want to work through. And then one of the most critical aspects is the legal analysis, where waiver technicalities either crept in or were identified from the very beginning. We have our attorneys who look at those, identify the regulations that are related and what we would need to do to ensure the waiver was approved by CMS. As necessary, the attorneys get engaged with CMS in the negotiation process. Also critical to this process is going to be data analytics. And in just a minute, I'm going to look at our actual proposal and sort of how we broke that out into the different tasks. But we know that this is one of the critical kind of underpinning efforts that's going to guide all of the additional processes under this. If you don't have good data analysis, if you don't know how to use the data, how to interpret it, how to manipulate it, which is the word that everyone uses, doesn't always have a positive connotation, but it's how to use the data appropriately. Looking at Medicaid cost drivers, and again, looking at the private market as well to the extent relevant information is available, doing the comparisons, figuring out what's different in your commercial market than you're doing in your Medicaid market. What are some of the things that you might want to do differently, things that work on the commercial side that you might be wanting to do on your Medicaid side. Especially focusing on those high utilizers or the frequent flyers who tend to use the emergency room. Especially in your private option, you've got people who are driving the cost, the typical 10% that are responsible for 70% of the cost. Some of that you won't ever be able to fix. People get old, people get sick. But there are a good number of those benefit users who are using it because it's convenient, because they don't have access to transportation, because they simply don't know, or they don't know where to go, or they don't have a primary care physician. A lot of it is education and training, which is one of the things that